Good evening, everyone, and welcome to The Perfect Fit, Tailoring Hemophilia A Management to Each Unique Patient. Tonight, we're going to be welcoming members from Manitoba Chapter and Hemophilia Ontario to participate tonight to talk about something that we're all very excited about. We're at a particular time in the evolution of the management of hemophilia that is very exciting and will allow us to tailor our treatment to ourselves. So on to the next slide.
So thank you for that intro, Christine. Just a couple quick housekeeping notes before we move on to the actual presentation for tonight. I am seeing the numbers of attendees also steadily increasing, so we want to give everyone time to connect with us. Just a couple functionality items to point out. The first is we do have a poll, and it's just a couple questions. So you'll see, I'm launching it right now. You should see a pop-up window that looks a lot like what you see on the screen here. Has two questions asking where you're joining from, as well as which patient population applies to you and where your loved one. And so please answer both questions and scroll all the way to the bottom and hit submit. That way we'll get your responses. The other functionality item we just wanted to point out really quick was, although you don't have the option to unmute those of you that are viewing from home, you can submit any questions that you have through the Q&A. And so you can find that at the bottom of your Zoom screen. Of note, when you're submitting a question, you can send that question anonymously. So you find that little checkbox in the bottom left corner of that Q&A window. Further, if you see questions from other participants come through, which you will see them come through throughout the night, you can certainly upvote ones that you find pertinent. And so all that does is it shifts the priority of those questions to the top of the list so that we can make sure that we're addressing them before the night's over. And I'll hand back to you, Christine and Boyan, for the intro and welcome.
Thank you, Rebecca. So there's some things we just wanted to go over before we started. And the first is to let you know that this presentation this evening is a collaboration with the Hemophilia Society, the Canadian Hemophilia Society, and your local healthcare professionals. That all the content has been developed by the panel of speakers and was not influenced by the sponsor. Of course, we all know how very important it is that we give you information that is done by our panel of speakers and our healthcare professionals. In an effort to maintain a non-promotional initiative, we ask that there be no mention of specific brands during this presentation. So if you can, please, that includes the questions. And financial support is gratefully been provided by Takeda Canada. So thank you very much for supporting this initiative and allowing us an opportunity to learn more as we go through our experience with hemophilia A.
Hi everybody, my name is Boyan Piernat and I'm going to be one of your panelists tonight. I'm going to be doing the intro of the other panelists. I'm the coordinator for member services and support for Hemophilia Ontario, and my co-facilitator there is Christine Kilback. She's already introduced herself, but she's the executive director of the Canadian Hemophilia Society Manitoba chapter. Our first presenter is Dr. ALFONSO IORIO, professor at McMaster University. He's the Hamilton Niagara Hemophilia Program Director, and he's the chair of the AHCDC, Canadian Bleeding Disorders Registry Committee, and the co-chair of the World Bleeding Disorders Registry Committee for World Federation of Hemophilia. We also have Vanessa Bouskill, RN, nurse practitioner in pediatrics, from the Comprehensive Bleeding Disorders Program, Division of Hematology Oncology, and she works at the Hospital for Sick Children. We also have a member of the community who is a severe hemophilia A patient, Michael Wilson, and he's going to be here to provide the personal experience and perspective of somebody who lives with hemophilia. Next slide. So our learning objectives for tonight, I'm just going to read them all to you because I'm sure you'll enjoy that, are an overview of our current approaches for non-inhibitor hemophilia A patients in Canada. 2, to understand how hemophilia A management can be personalized to an individual's unique lifestyle. And 3, to discuss how an individual living with hemophilia A can benefit from a personalized management strategy. Without further ado, I'm going to pass it over to Dr. Alfonso Iorio to get us started.
Thank you, Boyan and Christine. And thank you to the organizer and the sponsor for this event. I think I can skip over this slide and if I can.
Dr. Iorio, I see your mouse there. Just try clicking on the slide one more time and you should be able to move it forward. There you go.
Okay, yeah, excellent. And move directly into the matter we are going to discuss. I think we want to make a few points on definition of hemophilia. We all know hemophilia come in different flavor, severe, moderate, mild, but this is particularly important when we plan of discussing tailoring. Essentially what you see here on the graph is that factor VIII vary in the population from 50% to 150. And we call this space the normal space. We actually call it normal down to 40 for some historical reason, really based on the fact that you may have slightly lower than normal values and still don't have essentially any spontaneous or abnormal bleeding tendency. Then from 40% down to 5, we call the disease mild. Still is disease, still you need to have a gene mutation to be in this range. This is also the range where a few carriers happen to be. Most carriers, they carry the disease, but they are in the normal range. Others are in the mild. You can be in any of these ranges, but mostly carriers will be on the normal or mild. Now, mild is 40 down to 5. It's not common to bleed, but still bleeding is almost sure if surgery happens without increasing factor VIII, and sometimes traumatic activity can cause bleeds even repeatedly. Then we have the space for moderates, 5 to 1%. In this range, bleeding is very unpredictable. Some of the moderate patients, they essentially bleed as much as severe patients. Some other, they really only bleed for surgery. There are many few patients in this area. We have about 45 or so percent severe, 45% and so mild, and in between 5 to 10% moderate. We'll come back to moderate in a second. If the factor VIII is non-measurable, if it's below 1%, we call the disease severe. Now, I told you moderate can bleed as much as severe, but usually in a good half of them, there is no spontaneous bleeding. There is bleeding with high intensity activity or with trauma. Severe disease is where instead spontaneous bleed do happen and do usually start early in life, both in joint, muscle, and elsewhere. I told you we would have gone back for a second to moderate. What we discovered by looking at severe on prophylaxis is that we can make them, we thought similar to moderate. We increase their factor level by giving them treatment, and they end in being like moderate. They stop bleeding spontaneously. Actually, recent data from UK presented at ESTH last year show that patient on prophylaxis, severe patient on prophylaxis, they actually bleed less than moderate because they spend most of their time in the mild range and only some of their time in the moderate, while moderate spend all their life between 1 and 5. This is a concept we have understood very recently, and actually in Canada, like in UK, moderate patients have worse joint than severe who have been sticking to prophylaxis. Now, I wanted to spend some time on this slide because this is really explaining what is the goal of care. The left plot here is exactly as the previous one, but this time is showing you 4 different levels of activity, baseline spontaneous activity. So you have severe here, below 1%, moderate to 5, and then mild over here. And this is the number of annual bleeds in absence of treatment. And you see that severe patient, they have 6 or more. Moderate, they have 2 to 6 bleed. And the higher the level, the lower the bleeding rate. And then above 6, still some bleeds. There are still some mild that may record some bleeding event. Above 10, 12, 15%, really, there are no bleeds. So again, there's a correlation between the factor level one has spontaneously as their own baseline production and the number of bleeds. If we move to the space of treatment, the plot on the right reports what is the tendency to bleed. Actually, this is the probability of not bleeding. So 100% means no bleed at all, and 20 means very high chance of bleeding, as a function of the time spent below 1%. So if you spend no time below 1%, and if you are a child, these are children with pristine joint, if you are never below 1% and you are a child, your chance of not bleeding is close to 100. You will not bleed. And then instead, the more time you spend below 1%, the more time you have no factor 8 around or no factor 9 around, is similar for hemophilia B, the more you have a chance of bleeding. For adults, it's not as nice of a picture. There is a 50% bleeding, even if you are 0 hours below 1%. Even if you do a perfect prophylaxis, if your joint has some damage, you can still bleed because of the dysfunction of the joint. But again, you bleed much less. You have a higher probability not bleeding if you spend most of your time above 1%. And the more you spend below, the lower is your chance of not experiencing a bleed. And bleeds are definitely something we want to avoid. We want to avoid life-threatening bleeding. We don't see them as frequently as in the past when there was no treatment available, but hemophilia is not only bleeding in the joint. You can bleed in the brain, you can bleed in any vital organ, and this can be life-threatening or can lead to permanent damage. But for sure, bleeding in the joint over and over, starting from very few bleeds, is starting a process of inflammation, chronic inflammation, destruction of the joint, and then it's sort of a spiral where every bleed will make the chance of the following one more and more likely. So we want to minimize or avoid at all, if possible, bleeds. How do we do that? Well, we'll try to teach our patient to beware of which activity is appropriate for specific factor levels, or if you prefer to think it the other way around, which is possibly more supporting a normal life, which factor level is required for safely performing different level of activities. So reading or doing office work, staying in front of a computer, can be done safely at very low level of factor, 3 to 1%. Mild physical activity, we have depicted here a child biking, 3 to 5%. So if we were able to get 5% factor 8 at all time, this kind of activity would be completely safe. As soon as you move to high intensity physical activity, you require to go in that area between 5 and 15% above the level of moderates in the mild space. And even more so if the sport activity become intense, some kind of contact sport, for example. Above 30 to 50, you need for major surgery follow-up, you need for very high impact sport, you need for recovering for trauma. And above 50, you need to be if you want to survive surgery. Now, this is essentially the decay of factor after an infusion. You start up here, and then over time, you go down. So in a way, you can think of times of the day and times of the week after an infusion where it's safe doing different kind of activities, or vice versa. You may imagine to phase the infusion with the activity. If a young adult is playing hockey on Monday, Wednesday, and Friday, why not infuse those days? And maybe in the afternoon if the game is in the evening. It's not that easy to overlap the decay, the disappearance of factor from the circulation with the activity you want to do. But this is the basic concept beyond PK contribution to tailoring. There's another huge contribution, and is the concept that everyone is different. We are a crowd of people. We work together, we know each other. We are all more or less similar, but we have many, many differences. And one of the differences for hemophilia patient is how well they recover factor activity after an infusion and how fast they eliminate factor VIII. For each of these time points, this is time, and this one is the concentration. And you see how spread the values are. After an infusion, someone will be as low as 25, someone else as high as 250. And then over time, the activity diminishes, factor is eliminated, but there is still a lot of variability. Patient can be 3 to 6 times different in the level they achieve over time, where they start, where they end. Not knowing where everyone is will make it very difficult to provide everyone optimal treatment. So if we were to treat everyone the same way, the classical Malmo prophylaxis regimen, 20 to 40 units per kg, 3 times per week, Monday, Wednesday, Friday, 30 units per kg, we would have someone that gets insufficient treatment, someone else that gets too much. And someone will be injecting for no reason. When we think of too much, we are not really worried about cost. We are not really worried about waste of resources. I mean, we care for that, but we are more worried about limiting your activity, or when you would be able to do more, because your level is higher than we would expect, and we should not limit the range of activity that you would be allowed to safely do, or the number of infusion is higher than would be needed. So over-treating comes at a price of additional useless infusion or excessive limitation of the activity that would be appropriate for that level. It's good to know if one has a good pharmacokinetics. And also, there are patients that would be under-treating and would be bleeding. If we know that the chance for them not to bleed is high, why waiting for the bleed to appear before increasing the dose? We could know and immediately switch to a more appropriate treatment. That's the base for tailoring treatment to everyone individual need. Now, it's not just PK. PK is how fast you eliminate your factor. Tailoring is a combination of many different aspects. So you know your age. I showed you that the protection from bleeds varies with time, is higher for the same level of factor in children as compared to adults. Varies with your specific gene mutation. How much you have been bleeding in your life is predicting how much you will be bleeding. So knowing that some patients bleed more than others is important to take in mind when we come up with a regimen. The joint status. The more the joint are distracted, deranged by the disease, the more intense treatment we need. adherence. You know, regimens that are easier to follow are usually easier to stick to, and the result is a better protection. And of course, if someone is spending most of their time in front of a computer, as I do, it would be important to know, and it might be less intense treatment, still very good protection. And the patient goals. Every one of us has goals in life. And one of the reasons to tailor treatment is to take those goals into account. Now, what I usually say at this point, commenting this slide, is that PK is one of many components if we consider that PK is how fast you eliminate factor from your blood. But if you think of PK as a mechanism that once I know the factor concentrate change over time for a patient, the specific PK on one patient, then is not just one slice of the pie. Then is the lens, is the magnifying lens that you use to apply any other consideration. Because if you think of it, age, genetic, bleeding frequency, joint status, even adherence, every one of these aspects will cause us to decide to treat more or less intensely, with higher or lower dose, more or less frequently. And all of that goes through the magnifying lens of knowing the individual PK profile and using it for building the personalized regimen. So yes, is one of many aspects, but is a bit of a particular one because it's needed for applying all the others. These are life goals collected from patients preparing for this webinar. And you know, you may read through and find the one that is closer to your own. And there's everything here from, you know, completing your own renovation to enjoying a walk after work, to do less prophylactic infusion every week, or join a basketball team in high school. And this is just the one we were able to fit on the slide. Again, tailored prophylaxis means sitting with your patient and understanding what their life goal is. There is no one goal that fits everyone. There shouldn't be for full enjoyment of life. And then that goal is shared with the team and is used to come up with what regimen is more appropriate. And you know, the key person is difficult to identify. There might not be a key person. In each different situation, there might be one of the professional that plays a more critical role. I usually tend to downplay my own role. You know, I think that in the end, I have the pleasure of acting at the end of the consultation with all the information that was collected by all the other involved. But I have little doubt saying that, at least in my own experience, most of the heavy lifting is done by the nurse. For many reasons, the nurse is the contact point between the patient and all the rest of the team. The patient go first to their nurse, and through the nurse, they get access to the team when the nurse is not able to answer that question directly, which in most cases is. And I think it's part of being nurse, part of sharing the goal and sharing the global holistic care of patient. We doctor, we tend to use mostly our brain, and we try to connect knowledge with what is needed for the patient. Nurses, they use their knowledge, of course, at best, but they also put a lot more heart and soul than we do in their job. And when it comes to tailoring treatment, understanding the goal, translating into something that is doable, their contribution is really unique. Before leaving space to the nurse we have on today, I have two quick examples. This is a patient, a middle-aged patient, on a Monday, Thursday treatment, twice a week, 2,000 units, and start having some bleeds on the long interval. So this is information out of WOPS, 2000 unit on both intervals, the peak is around 1. So it's an appropriate dose. But on the 3 days interval, the trough remains above 1%. On the 4 days, goes below. So one starts saying, okay, may well be that the bleeding is because factor is too low on the Sunday. Sorry, I should not. Oops, I'm doing worse than worst. Can I go back in any ways?
Absolutely. Here, let me help you go back. Give me 1 second here.
I was able before, but not this time. Here, no,
Right.
one more. One more. Thank you. No,
Nope.
one more, please. Back.
Backwards?
Yep.
Perfect.
One more backward, sorry. No.
Here, I'm going to the beginning.
Yeah, okay, here,
okay,
here it is. Thank you. Sorry, guys. So I was saying on the short interval, you go below, on the long interval, you go below the 1%. Maybe this is the reason for the bleed. Now, in summary, and this is again something that tools like WOPS calculate for you, 44,000 units per week, the 2 infusion, 88% above 1%, and about a third of the time above 15. So, you know, yes, there is some time below, but not a lot, and should be on the Sunday night. We would not call this regimen unlikely. And in fact, this patient went on for long without bleeding. Now, what we have recently made available in WOPS is the possibility of testing different doses. We didn't have this function, but many asked, okay, in a situation like this, we would like to increase the dose on the Thursday. So on the Monday, to cover the short interval, we give 2,000, and on the Thursday, we give 3,000. Now, we made this possible more for an educational role than anything else, because what happened if you do this is that you see that now the peak goes up from 0.9 to 1.3 on the higher dose, but the trough still is below 1%. You increase the peak, but then it goes away exponentially and it continues to be too low. And you see here from 88, you go at 92 above 1, which is not a huge advantage, and from 27 to 32 above 15%. So it doesn't change a lot. 1,000 units more per week on the long interval don't do a lot of effect. You can even try 4,000, 2,000 on the first and 4,000 on the long. So Monday, Thursday, the peak is now close to 2. Still, you don't get to cover the long interval. So what's the value of going this way? You will try, you will see that likely the patient continues to bleed, still not covered completely, still minimal increase of time above 3%. If instead you were to go from this one to 3 times a week, you would keep the same peak, you would cover completely, you would increase, yes, from 4 to 4,600, but now you would be 100% covered, and you would have the same impact, which is very minimal, on the 3 and 15%. So again, is this useful? It's useful to communicate and to understand what is better to try. You can try going high with the dose, it won't likely not make a difference. We find this very useful in discussing with patients. My second example is someone, in this case, is a little more than a child, playing soccer on Tuesday, Thursday, and Saturday. Well covered with, oh, sorry. Can you go back, Rebecca? I'm sorry.
No problem.
My trackpad is very sensible, and yeah. So Tuesday, Thursday, Saturday, 2,000 units, enough to protect the training. There are occasional matches on Sunday morning, and we recommend give another infusion. Now, again, if you simulate what happened, you don't really need for a Sunday morning match to give a 2,000 unit vial. You could give a 1,000, you would have coverage. Would you save those 1,000? That I don't know. But again, it's important to see what the impact can be. Now, 2,000, 1,000 is very likely one vial. You may not even want to have the two size, but for some patients that need to mix two vials for their standard prophylaxis, being able to cover an occasional sport activity with only one vial, save times, and maybe consider the value. Again, simulating this kind of regimen visually, graphically, may be useful in understanding why it's important to treat at given time and what you can achieve with different doses. And with this, I think I'm done. And I'm happy to introduce Vanessa. Vanessa was already introduced for her title, but she will now leading you into the meat and real hard stuff of tailoring prophylaxis from the perspective that does matter. Vanessa.
Thank you, Dr. Iorio. Before we move on, we just had a couple of questions from the audience before we move on for you that you might want to answer right after your presentation.
Absolutely. I thought we were discussing at the end, but I'm very happy to take question now.
We'll do a little bit of both, I think. So one question we got from the audience, I think related to the very beginning of your presentation with defining hemophilia, they ask, if you can move from a severe to a moderate, can you move from a mild to a moderate? I'm
trying to think, maybe it's the opposite. If you can move someone from severe to moderate with prophylaxis, can you move a moderate to a mild? Yes, and I think that's really needed because moderate actually with the current way we think of life and activity and achievements may not be protected enough. So particularly now that we enter the era of gene therapy or non-factor replacement therapy where we start targeting levels in the 10–15%, that's a goal not only for severe, but may well be a goal for moderate. So yes, the answer is you can change both severe and moderate to mild.
So Dr. Iorio, I have a follow-up question to that. If you are a moderate and you're experiencing a bleeding episode, do you expend the factor VIII that you have naturally? Do you use up that store, or do you always have the same amount of factor VIII if you're a mild?
So it's a very good question. What we know is that under stress condition, like running on a treadmill, and this was an experiment that was done at Sick Kids by Manuel Carqueo, you release the factor concentrate that is stored in your veins wall. Usually you have twice as much in the vein as you have in your circulation. So essentially, you may be able to go from 3% to 9%. Is that increase making a difference? And consider it's released, but then is eliminated quickly. I'm not sure what the clinical impact is. Technically, should be possible. For sure, a mild, given the DAVP, goes from 15 to 45, can even do surgery without bleeding. For a moderate, the impact is not known. And the main reason is that you don't expect a huge increase. So it might not be enough.
There's maybe one more question we should answer before we move on that's getting a lot of upvotes in our chat here, which is, when should I be getting a PK?
Good question. I would think if you have not gotten one, get it as soon as you can. It's never too early. PKs can be done nowadays with essentially one single visit. You have to agree with your clinic how many days before you treat. Usually it's 2 days before. So get to clinic about 48 hours after an infusion. And then in clinic, they will do a sample, a dose infusion, and a 3-hour sample. With those 3 points, knowing the dose, having the that is 48 hours after a previous infusion, and a 3-hour, you can already do a PK. So it's not really complicated doing a PK study. If you then live close by and you want to go back on day 2 and have a 24-hour, that's good, but it's not needed. So I would think there's really no reason to delay on your current concentrate. Then my suggestion would be, if you change your concentrate, you know, because there's a tender and what you were on is not anymore available, or because you move to a different concentrate, I would do a new study on the new concentrate. Usually what we recommend is about a month after you are started. Get used to it, get a few infusion, and then have a PK study whenever is possible.
Perfect. Thank you so much for answering that question. I will save what we have in the chat for the end of the presentation. So I'll move on now to Vanessa.
So thank you, Alfonso, for your presentation. We'll go a little bit more into personalization from a nursing perspective and what that means for patients when you have discussions with your nurse, who's usually your primary contact at the clinic, as to how do you facilitate personalization for yourself? Well, there we go. So as Alfonso had mentioned, personalization is really the standard of care, I think, going across chronic conditions now within the medical field. We know that traditionally it was always everyone with a certain diagnosis would then be put on a preventative therapy. As in hemophilia, we'd put you on prophylaxis, put you on a standardized regimen, and basically every severe patient would be escalated up. And this was typically called the Canadian dose escalation protocol that we use, where what people would be on once weekly, escalated up to twice weekly if their bleeds continued, and then 3 times weekly and every other day, depending on their bleeding phenotype or bleeding tendencies. So the goals of personalization really now in chronic conditions in general, and particularly in North America, is looking at actually optimizing therapy and reducing the amount of prescribing that's based on trial and error. So doing the one-size-fits-all approach. We know that it's definitely a safer and more optimal dosing option. We know that it actually improves patient adherence by using patients' goals and perspectives while we're making the decisions regarding their management. And we also definitely know that if we're personalizing care and therapy to someone's lifestyle and activities that they want to be doing, whether it be playing soccer with their grandchildren, going for a walk with their dog, I really believe that if we're able to have a conversation with patients and share decision-making with regards to what works for them, it improves adherence and improves quality of life. And ultimately, it will reduce the costs on the healthcare system if we're minimizing any comorbidities or chronic changes within our joints, leading to more hospitalizations and surgeries. So with the role of the nurse, when I was given this topic, I think that it really is not necessarily the role of the nurse. It's something that the nurses take on quite often, but it really is anyone within the hemophilia comprehensive care team to have the opportunity to discuss what the patient goals are. So what do they actually want to get out of prophylaxis or not prophylaxis, and how do we support those goals and making them optimal for you? So a lot of the education falls on the nurse, so talking about what actually is pharmacokinetics, how do we personalize the approach for you, having an understanding of half-life, so what the body does to the drug, how quickly it degrades in the system, understanding peaks and troughs and why they're important, so why we have high levels and low levels, and why do we need to know what those mean. Explaining time to 5%, 3%, and 1%. So what is our target for the patient? And then advantages and disadvantages of PK-guided therapy. As Alfonso mentioned, PK really influences almost every facet and personalization of care. So if we have an understanding of what your half-life is and or your time to 5%, if that's our goal, how do we modify potentially your regimen to make do for your lifestyle and what things that you'd like to participate in. Again, coordination of care is really explaining the process and how do you time your blood samples and your infusions at home to make sure we have accurate records and accurate timeframes to actually use population PK app, which I'll go into a little bit later, which will allow us to get a full half-life without having to do multiple time samples. So as you saw this before in a little bit different graphic, but basically it's just showing you that personalized treatment takes every aspect into account. And what was interesting to note is one thing that wasn't mentioned on Dr. Iorio's presentation was patient access. So venipuncture, some patients have difficult access, some patients have easier access. So really sometimes that does limit the amount of infusions we can do if there's no central line, particularly in pediatrics. And again, as we mentioned, focusing on the pharmacokinetic response or the PK profile of you. So what exactly is pharmacokinetics? It's really what the body does to the drug. So after you infuse factor VIII, it's exactly how the body takes it in, absorbs it, distributes it to where it needs to go, how it starts to break it down or metabolize it, and then the elimination, which is the curve which is shown below or before. So why is that important? It's really important to understand because, as Dr. Iorio mentioned, we want to make our patients severe to moderate or potentially our moderates to mild with prophylaxis. And if we increase our time above 1%, we know that we'll have less bleeding. So if we are below 1%, the increase of breakthrough bleeds is much more common. And knowing that the factor VIII pharmacokinetics between patients is very, very different, it's really important to understand what yours is for us to have an understanding of what your regimen should look like. And we do know that pharmacokinetics do change over time. So as you're a young child, your pharmacokinetics, your half-life is usually shorter than you are when you're an adult. So knowing that it increases with age, this is something to have a discussion with your clinic about, because if you're having it when a pharmacokinetic study done when you're 4 years old, it will be very different from when you're 10 years old and let's say 20 years old and then potentially at 40 years old. So it might need to be repeated a few times. So this is just an example of 2 different patients to show the variability of half-life between them. So they're both given the same dose, 30 units per kilo of the exact same product. And if you see here on this graphic, it shows you the one patient on the left side of the screen has a short half-life in comparison to the long half-life and how long it took for them to reach 1%. So it's just to show you that the elimination of factor VIII in patient A versus patient B is variable, and they receive the same dose and the same product. So again, as I mentioned, personalization is really based on individual needs and lifestyle. We know that there are certain optimal factor levels for different times in your life, for different activities. So understanding where a patient is in their life, as well as what things they like to participate in or do, that will then influence the level that we're going to target. So this graphic just shows you that an example of the degradation of a factor VIII infusion and where someone could be safe on those levels. So how do we do this from a clinic perspective? So really, we started from a weight-based approach. So as Dr. Iorio mentioned, the one-size-fits-all approach, so the Malmo protocol, which was 3 times a week of 30 units per kilo. But then we realized that there are some patients being underdosed and overdosed, and how do we actually change that based on what their PK is? So there's 2 different platforms that are actually available. The platform that is used, both of them have been used across the country. My PK Fit is sponsored by Takeda. This one actually is used only for their products because they use the samples from their preclinical trials before licensing to actually show the pharmacokinetics of Advate and Adinavate. So this one is product specific, where WAPS Hemo is housed in Hamilton. Dr. Iorio is, I would say, I guess, the creator of this. And he really, with his team, helps with looking at all factor products available. So you can enter which product the patient is on and enter their levels to then generate their PK. And as he showed previously in his presentation, you can modify this based on what kind of coverage you would like for factor VIII levels and modifying the dosing or modifying the frequency. So an example of a PK assessment, so now we know that there's population PKs, we're not doing 12 time blood draws. It's actually a lot more convenient. There's two different examples that you could do. One is you come to clinic and infuse your own factor product in clinic. You have a blood sample drawn 3 hours after the infusion, and then again come back and have a blood draw between 24 and 72 hours. The other option, which we typically do at Sick Kids, is try to do it all in one visit. So if any of you are patients of Sick Kids, when we have switched over products specifically, we've done this more in the last couple of years with all the tender changes, we will do a level. So we'll ask you to infuse at home 24 to 72 hours prior to your appointment to actually write down the units that you received and the exact time and day that you got it. We will do a blood sample when you come to clinic. We will then infuse immediately after with the same needle another dose of factor and write down the specific units and time. And then 3 hours after that, we will then take another sample. So you're able to actually do all your PK within one visit within clinic. So these blood samples are then put into those two apps that I mentioned to you, and they give you different curves. So there's different screenshots or different usability of the programs, but what you'll note here is both of them will give you your curve. They will tell you your time above a certain percentage, so 5, 3, and 1%, depending on how you change it in the system. They will give you your week schedule of what it actually looks like. And on the one, on the right-hand side of the screen, it will show you, you can actually modify to say your green times are safe zones for you and the red times are non-safe zones for activity. So it helps with also teaching with families. Also, if you were to have the app yourself, for my CBDR, it's linked in with my WAPs. You can actually have your whole schedule of your infusions as well as any bleeds that you've had. And then you could, if you've done blood samples at your clinic, they can link it to my WAPs and show you your curve. Then for my PK Fit, very similar is that you can have your infusion logs as well. In this case, it's a battery versus your actual degradation curve, which is your exponential curve that comes down. And it just shows you how much percentage you have. You can also look into the future of how much you will have. So let's say you're planning for an event, you have their big 4th birthday or 5th birthday, you can actually plan to say, are they going to have enough for their birthday party, or should I be infusing them before? So it's kind of a good way of looking into planning, because I know that sometimes can be challenging with families. And then this is an example of what it will look like. So your current factor VIII levels and then your future factor VIII levels of where you'll be at, which allows you to personalize based on what you're going to be doing the next day. So I'm just going to give you an example case that I've had at our hospital. This is not the patient, it's just a stock photo, but it was interesting to know the decision-making process around this and how we came to a consensus on what his therapy or his treatment plan would look like. So this is a 13-year-old male with severe hemophilia A who was diagnosed on cord blood due to an extensive family history. So for their family, it wasn't an adjustment with the diagnosis. They knew he was affected, and they knew from their family experience what to expect. So it wasn't a challenge to start prophylaxis on him. So, and he also didn't have a severe bleeding tendency. So when you think of severe hemophilia, you think they will bleed by the time around 1 year of age of their first joint bleed. He actually didn't bleed till about 2.5, and he really had minimal bleeding episodes for the first 4 years of his life. So didn't initiate prophylaxis till about age 5, which is quite abnormal. He was worked up for other clotting disorders to see if it would balance out his bleeding tendency, but nothing was ever found. So he started once weekly at age 5, but then escalated as he got more active. He started to have more bleeds, so twice weekly. And by age 5.5, he was on twice weekly, and then full dose prophylaxis by age 8 due to recurrent ankle bleeds. And as you can see, this is not optimal for the amount of bleeding episodes that he did have. But when we look back, this was a few years ago when we were still using the CHIPS protocol on how do we escalate based on bleeding tendencies. So not ideal for this patient to have this many bleeding episodes. So in hindsight, we probably would change his management sooner. But going forward for this patient, we've really optimized his therapy, and you'll see below. So really was an active skateboarder, and we always talked about the importance of protective equipment, and we supported him in doing this because we knew that he was going to do this regardless of our recommendations. So we started to talk about what does this look like going forward. So despite being on every other day prophylaxis, he still was having breakthrough bleeds. I put Advate there. This is not a push for Advate. Advate's not available in Canada anymore anyways, but for an understanding that it is a standard half-life therapy at the time. So no extended half-life therapy was available in 2015. Then we had a discussion around why there was poor bleed control. So were we optimizing dosing? Were we optimizing his frequency? Or was there an issue with the adherence to the prescribed therapy? So maybe it was the infusion time of day that he was doing. Was he consistent with times, or was he doing it randomly at different times of the day? So leaving some of his windows of really low levels and potentially going skateboarding, or was he missing infusions? So we started to use point of care ultrasound around 2016, I would say, and more so in cases that were active bleeds, or in cases that we needed to really teaching to show someone what their joints looked like. So we did some point of care teaching with the patient so they could see the true differences that we were seeing on imaging. So in the middle screen, it shows you some ultrasound pictures. So then we actually went to MRI and showed the soft tissue and bony changes on MRI. So you can see some on the left side of your screen, some bony irregularity or loss of cartilage. And then on the right side of your screen, those little circles in between the two bones, those are osteochondral cysts that are occurring. So bony changes, which is not a good thing. So we talked about modifying his frequency or time of infusion, potentially optimizing dosage if that would help. And then talked about adherence. So really showing him physically what we were seeing and why we were concerned. And then we used his samples from 2015 to actually optimize his therapy and propose different options. So I think what's key here is understanding that we propose different options for the patient, didn't just show them what they should be on. So when we put the timed blood samples in, that's what it generates. And then you generate a half-life. So it shows you that this patient had a half-life of 12.7 hours in comparison. So you can see the blue line there shows you the estimate in the population. And then his samples are the blue diamonds. So the first option we gave was, okay, we'll go to every other day, 42 units per kilo. And that means he'll never drop below 4%. And then the second option, we said we can go 500 units daily, so only 11 units per kilo, and then there would be no time below 4%. Which was really interesting when we had the discussion with the 13-year-olds, because his parents basically said they couldn't force him to do his infusions. He was doing his own infusions, so they wanted him to make the decision to buy into what we were actually having discussion about. So he actually chose to go to daily therapy, which I found really interesting for someone of that age. When you think about giving infusions to yourself and having needles, it's not something that I would say most patients want to do. But then again, all he said was he just wanted routine, and he wanted to know that he didn't have to think about his hemophilia if he wanted to go skateboarding with his friends. So he knew that if he gave it every morning, then he wouldn't have to worry about that day if they wanted to go after school or his friends came to the door, and he didn't have to say, oh, wait, I have to go give my infusion. He just wanted to have more normalcy. So we totally agreed with him, understood where he was in his life and where he was in a transition in adolescence. I think it's hard in general to be an adolescent patient. So understanding him, our chronic condition and being an adolescent male, we decided, okay, he's decided on daily therapy. I asked him just to buy in for a couple of months and then see how it went. So he bought in for 2 months' time. And with the decreased dose, increased frequency, and we saw basically improved physical findings from our physiotherapist. Point of care ultrasound showed improved soft tissue changes, less joint pain, no bleeds reported, and he continued. And I'm happy to say that he's actually on now an extended half-life therapy, and he's actually on optimal therapy, which is every 3 days, and continues to do extremely well on these regimens. But he stayed on daily therapy for 2 years prior to switching over to extended half-life therapy. So an interesting case, something that really important, I think, as clinical people for us to understand is that always present every option to a patient, because the option you might think is the best option to choose or optimal or more convenient may not necessarily be what your patient is in agreement with or what they feel is the same. So this is an example of patient experience or nurse experience with one of our patients and a long journey, and definitely has come with positive outcomes. But I think now it's, if there's questions, I'm happy to answer them. And then we'll hear actually a patient experience, which I think is great to hear another side from the perspective on the other side and not from a clinical person. Thank you.
Thank you for your presentation, Vanessa. I learned so much from it. There is a very interesting question that we have, considering your role working with pediatric patients. How can caregivers assist with personalized care management?
So I really think it depends on where you are on your kind of trajectory. So are you at the beginning stages of diagnosis, where you maybe not even started prophylaxis yet? So thinking about prophylaxis and what that potentially looks like, engaging your child, having your child understand what it is to have this condition, have them engaged in community. So seeing other kids do the infusions, knowing what is of norm for them potentially. And then as you kind of get older, I think as you start to bridge over into the adolescent age, I think it's really important. It's hard for parents to do, and I can't imagine having to do this, but giving up that control and making the adolescent make the decision for themselves. I think that a lot of times we try to tell adolescents what's important or what they should do, but it's at a time where they're trying to exert their own independence as well. So it's a time of rebelling back. So if you're going to just tell them specifically, you should be doing every other day. You heard the nurse, she said every morning, you never do it when you say you're supposed to do it. I think they see it as a time to rebel, and they'll just do it when they feel like it. So how do you engage them and have a discussion of what activities do you want to do, what's important to you, and then how do I help facilitate that? So how do I help make a regimen that makes you safe and then also you happy? So I think when parents are able to give up that control and allow that, I think adolescents do really well in taking responsibility. They know a lot more about their condition than I think we give them credit for. That's part of I think as adults, we try to always take care of our children until they're adults, but then I think it doesn't do them justice later on. And then I think as a caregiver, potentially for a partner or even for a parent, let's say an elderly parent, I think that the mindset kind of shifts a little bit. I'm not an adult treater, but I have an understanding just from personal experience. How do you take care of an older parent? So what does that look like for them? A lot of men with hemophilia didn't survive until elderly ages because of the tainted blood scandal. So what does that look like now? And how do we ensure that they're safe? Are they at risk for falls? Should they be on prophylaxis? Do we advocate for home therapy for someone to go in to help? Are they able to do it by themselves? Or would you like to help with the therapy? I think that is another way that you can be engaged. I'm not sure if that fully answers the question, but I think it's different across the whole lifespan.
Vanessa, I think we have time, excuse me, for one more quick question to you before we move on to Michael. Can patients change their goals over time, and especially in the case of younger patients?
I would say definitely. I'd say every time you come to clinic, or even if it's not working for you, goals can change. Just like everyone in life has goals for the next 2 years, 5 years, 10 years of what they want to achieve. I think that we can always be modifying and tailoring to what they could be.
Thanks, Vanessa. I know we have more questions to ask of both you and Dr. Iorio later. But now we're going to move on to one of the most brilliant parts of our community, and that is that we can learn from each other. So I'd like to welcome Michael Wilson to speak to you about his experience, And I'm sure that we're going to learn a lot from Michael. And thank you for sharing with us, Michael.
Thank you so much, Christine. First of all, I'd just like to say I'm very honored to be asked to be here tonight. It's so many years of taking from the Hemophilia Society and the medical profession that's involved with the Hemophilia Society. And it's whenever I'm asked to do something, whether it's trials for a new medication or whatever, I say yes, because it's basically time to pay back. And so, yeah, and I'll go on with, start with my little story here that I've written about my experiences with hemophilia. I'm a 60-year-old severe type A hemophiliac, and I've experienced many breakthroughs in hemophilia care in my lifetime. In the 60s, as a young child, I was given whole blood to treat internal bleeding episodes as needed. In the late 60s, early 70s, they figured out how to separate the clotting factor 8 from the whole blood, and cryoprecipitate was developed. These early treatments were given only when there was a bleed. There was no preventative care. This period of time was extremely hard on my joints, and a great deal of damage was done to several of them. I just want to inject some things in here as far as in grade school, I missed an average of 50 days a year. So that'll give you an idea of how many bleeds I had a year when I was a kid. My right arm is about 2 inches shorter than my left arm due to the great amounts of bleeds I had into my right shoulder. My first joint surgery was in my early 20s, and it was to my left elbow. They removed the radial head and inserted a plastic radial head. The original radial head, which is a bone in the elbow joint, was so badly deteriorated, it wasn't doing its job. So they took it out, put a plastic one in. At 42, I had my first knee replacement. 52, I had my second knee replacement. All of this, in my mind, was due to the lack of care that we had at that time. There was no hemophilia treatment center in the 60s when I was growing up. We went to our family doctor. And Vanessa, how you were saying earlier, how the adolescent, give him more credit than you're giving him. He knows more about his medical problem than we realize. I can't tell you how many times I went to my family doctor as a kid, and he told me, Michael, you know more about your health problem than I do. So that's a good example of how things have changed. Every time a new product came out, it gave me more freedom than the previous product to do what I wanted to do without having to worry about an internal bleeding episode into one of my joints. With the introduction of the freeze-dried factor VIII concentrate in the mid to late 70s, also came prophylactic care, where I would give my own injections at home every 2 or 3 days. This greatly reduced the amount of internal joint bleeds that I was having. With giving the injections on a regular basis, I was able to keep my factor VIII at a level that would prevent me from having spontaneous joint bleeds. In 2015, MyWOPS was developed. I remember being at my hemophilia clinic for an annual checkup and being told that they were now doing pharmacokinetics, or PK tests, to personalize one's hemophilia care. They would take a blood sample prior to a factor VIII injection, and then a few more samples immediately after, as well as 24 and 48 hours after the injection. This blood work helped them determine what my factor VIII peak and trough were. With these levels, they were able to create a graph which would tell me where my factor VIII level was at any given time after an injection. These values were entered into the MyWOPS app at the hemophilia clinic, which was then connected to the MyWOPS app that I had access to on my cell phone. The MyWOPS app worked in conjunction with the MyCBDR app, where we had been keeping our infusion records. When I record an infusion in MyCBDR app, the MyWOPS app is automatically updated with my current factor VIII level. The MyWAPS app then reduces my factor VIII level as time passes according to the according to the PK testing that was done. I have always thought it would be so helpful to know what my factor VIII level was at any given time. And now, like many other things in our world today, there is an app for that. I've also heard recent news about an actual testing unit, much like diabetic would test their levels. There is something in the works where it's a little unit that we prick our finger and we can tell what our factor VIII level is. So there always seems to be more advancements coming. Just when we think we know it all, somebody comes up with another idea and invents something new. So let's say I had my infusion yesterday morning and today I would like to go to the gym, or a friend drops over and invites me on a bike ride. Well, with the MyWAPS app, it is as simple as pulling out my cell phone and clicking on the app to determine if my factor VIII is at an acceptable level to do a strenuous activity. Also, if I would like to do something tomorrow morning at 9 a.m. and I want to know now what my factor VIII level will be at that time, I then go to the estimator part of the MyWAPS app and slide the control to 9 a.m. tomorrow, and the factor VIII level at that given time appears. The other advantage to the MyWAPS app is it is very easy for anyone to use. If I have had some type of accident that renders me unconscious, my wife could open the app and determine what my factor VIII level was at that given time, and give that information to EMTs or an emergency doctor at the hospital. I believe these two apps have assisted me in reducing the amount of internal joint bleeds that I have, and I am very grateful that they have been created. I cannot remember the last time that I had a major joint bleed. And I am certain that part of the reason for that is knowing constantly what my factor VIII level is with the aid of MyWAPS app. Like I said earlier, I've seen many breakthroughs in hemophilia care in my lifetime, most of these being improvements or advances in the products I infuse into my body. I would also like to include my CBDR and MyWAPS as some of these breakthroughs that assist me in living as close to normal life as I possibly can. Thank you.
Thanks so much, Michael. Sorry, Chris.
No, you go ahead. We're very grateful, Michael.
Yeah, thank you so much, Michael, for sharing that personal perspective. I think it's always good to hear how these things impact people, and also to have a sense of perspective on the history of how things have changed when we talk about what's coming next. So without kind of further ado, we can now move on to the question period, and I'll throw it over to you, Christine, for the first question to our panelists.
There have been some fascinating questions. I can't wait to move through these so we can find out the answers. So this would be for Vanessa and Dr. Iorio. Will my PK be the same for all products? So I would guess that they're saying for all extended half-life products or for all non-extended half-life products.
You want me to answer it?
Well, I can give it a first crack, and then Vanessa, I'm sure you can think of patient where you check before and after a switch. Unfortunately not. You may be better off with one or another product, and it's very difficult to predict. We are actually working on trying to understand which patient would benefit more by switching. But if you look carefully at studies where the same patient was given two different products, there are always some that do better on one and other that do better on the other. And I don't know their face, but I've looked at 25 kids switching due to a tender between two long-acting at sick kids. And some of them, 6 or 7, were doing more or less the same. Some other were doing better on the new, and some other were doing better on the old. So no, it varies. It's a combination of the one product and one patient.
Thank you. You answered that in totality.
Thank you.
All right, we've got our next question here, again focused on the way that pharmacokinetics works. So this person is asking, can certain prescription medications interfere or alter pharmacokinetics of factor VIII? If so, which ones?
I'm not aware of any. Besides DDAVP, if you give DDAVP and factor VIII together, DDAVP causes a release of von Willebrand, and it seems to increase a bit the half-life of factor VIII. But medication like, cholesterol pills or antihypertensive or antibiotics, they usually don't affect the PK of factor VIII, neither of factor IX. So I'm not aware of any medication. There are medications that usually we recommend patients to avoid, like aspirin, but it's not that they affect the PK. They just cause bleeds with another mechanism.
I think that if you wanted to answer it a bit further, and the fact that what can alter pharmacokinetics, I think if you look at if there's an active bleed, that can alter, like your consumption of factor VIII would be higher. If you are I'm trying to think of, if you have higher von Willebrand factor levels, your pharmacokinetics are better of factor VIII, because von Willebrand is a chaperone to factor VIII. So that can alter your, if you have a good or a better half-life. But I wouldn't say that something that you can take would change how factor VIII is broken down in your body.
Okay, Vanessa, I'm going to ask this question of you. How can parents of a child know if there's a joint bleed? Are there any visible signs?
So it depends on if the child's verbal or nonverbal. So if the child is nonverbal, it's a little bit harder to detect, but usually they're irritable and then not using the limb as you would expect them to. So an example would be if the child has an elbow bleed and they're only reaching for a toy with one arm, you try to tempt them to reach for their other arm that they're not using. They're not using it, you then start to look for abnormalities in that limb. So you start to look for swelling, warmth, and if it's a muscle, it's more so function and range of and then obviously range of motion for a joint. For an older child, usually they're able to tell you if they've had a bleed before, they're able to better articulate it. So they know it's kind of a funny feeling, they say, a funny bubbly feeling, tingling feeling. All patients have a different kind of aura at the beginning. And then they gradually progress to pain, inability to weight bear if it's a weight bearing joint, in like an abnormal gait, limping, then swelling, and comes later on. For a child that's never had a bleed, it's a little bit harder for them to articulate it, but usually they can tell you that something's not right. Sometimes it's a later signs of a joint bleed because they've never experienced it before. So typically those patients will show up with a more swollen joint. In an ideal case, as soon as they feel that kind of funny feeling, if you were to treat and we're able to minimize the effect of that bleed, then it doesn't take as long to rehab back and the reabsorption of the blood to occur. So it's always best if they're able to articulate something's not right for the parents just to infuse or the child to infuse if they're an infuser, because we know that if they wait longer, then it's going to take a lot longer, and the effects of the blood in the joint are going to be a worse outcome.
So much. So this is a great question for everybody here. How can I bring up wanting a more personalized approach to my care with my physician or nurse?
I think that when it comes to personalization, I think that every clinic is different and their experiences with it are different. But I truly believe that if you were interested in wanting to try to modify your regimen or your therapy based on what's best for you. I don't think any physician or nurse will turn you down. It's just opening up the discussion around that and just saying, I heard about this, would you be willing, or is this something that we could try? And obviously, if it's clinic that doesn't have as much experience with it, like they can always link up with another clinic within Canada. There's lots of clinics within Canada that do have some experience. And I'm sure Dr. Iorio and myself would be happy to speak to someone if they wanted to actually personalize your care more.
So this is a very good question too. How would I know that I would be a good candidate, and does this work for everyone? Maybe Dr. Iorio, could you answer that?
Yeah, I would think that it does work for everyone, meaning that it's worth trying in everyone. And as we have tried to convince you, it's pretty simple. It doesn't require a lot of effort to do a PK and then to try to see how this knowledge can impact the regimen of a patient. So there are patients that just discover that what they are on, their regimen is already optimal. So was that a waste of time? It's a confirmation that there's no need to change. If you had to fly overseas for getting that information, it would be a waste of time. If it's a matter of getting a couple of blood measurement, putting him into a system. But in most cases, you would find that there is some space for fine tuning of your regimen. It also depends very much on how you are doing. So if you are not having a lot of bleeds, very likely the most you can obtain from a tailoring exercise is to have less infusion. If you are bleeding, might make it faster to stop the bleed and find how much factor and in which modality you need to have it. Nowadays, for example, a test that is very useful for tailoring is blood group. We know very well that blood group is very impactful, and we would not think of low dose or very long interval in patient with blood group O. We were not testing blood group until recently. So there's a good chance that this will benefit most of the patients.
Thank you.
Okay, I'm going to roll the next two questions into one because they're both about apps. So the questions are, how can I access these apps, and are these apps available in all the clinics?
Vanessa, you want to answer, or?
I know that I think everyone can get on my CBDR and WOPS and my PK Fit. I think that the challenge lies in some clinics. I'm not sure if some have not gone through REB and have access to CBDR in the clinic. So I think there may be a couple in Canada that haven't. And maybe this might be the roadblock as to why the results are not on WOPS. Is that correct, Dr. Iorio?
Yeah, I think so. I would say that in general, my general answer would be to get on this app, you have to talk to your clinic. All of these apps are not for self-medication. They enable you to understand much better your treatment, and you can see, as Michael was saying, your concentration or the concentration you'll be in the future. But is really something that needs to be activated for you by your clinic, by your doctor, your nurse. And the reason is that as anything that has to do with health, some initial training, don't imagine a course, it's just a 20 minutes conversation, but some explanation about how to read it, how to interpret it is needed. And that's why all of these apps require a doctor or a center to activate them. But besides that, they are available for everyone. There is no cost, and they work on most phones or computers. So essentially, I would think that you have to ask your clinic. And if they say that is not available, maybe they have to activate the clinic first.
Okay, thank you. If you find that your clinic doesn't have the capacity to, if you're one of those few clinics, that would be a very good advocacy point for your chapter to be notified about and to take on. And so our next question is actually more of a comment than a question, but it's very apropos. Personalized care is both art and science. It takes the whole team working with the patient to articulate goals and evaluating outcomes to make adjustments as needed. It's essential that we continue to advocate for the integrity of our bleeding disorders clinics and the expertise needed to provide this kind of care and treatment. It should be the standard we work together to achieve and maintain. I'm sure all the panelists would agree with that statement. So the next question is, if the bone density is less in patients with hemophilia, is that not more of a correlation due to a more sedentary lifestyle as opposed to being a direct result of decreased factor level?
I'll try to answer. I did some research myself in the space of osteoporosis and osteopenia in hemophilia patient. And even if most of the research in Canada has been done in Calgary by Adrienne Lee and other in that group, for sure hemophilia patient, as you say, have a lower bone density, which means at some point a higher risk of fracture. If that is the result of some problem in the metabolism of the bone connected to low factor levels, or more a consequence of being less active, is unknown. There's a study ongoing that tries to compare if the bone density impairment is more on the side of a target joint as compared to the other. Sort of pointing to is more of a matter of being physically inactive or being asymmetric, but is not known. As a matter of fact, we know that we should try to facilitate or make it possible for a patient to be active, because no matter if it's factor VIII or inactivity, the only way to increase bone density or not to lose bone density is to stay active. So that's one of the good reasons everyone, including hemophilia patients, should be given a chance of exercising.
Thank you. There was a follow-up question on that same line, but you've pretty much answered it, where they were asking about physical activity having an impact on increased bone density. So I think we can safely move on to the other question there, which was, can you please explain more about blood groups? My son is O and he is severe A.
That was just related to Dr. Oyorio's comment on O blood group and the fact that von Willebrand factors are lower and typically in our O blood group, which leads to the lack of chaperoning with factor VIII, which then means the degradation of factor VIII is usually faster. So half-life is affected by O blood group. So usually patients with O blood group will have a shorter half-life in comparison to the average of that population.
And again, Vanessa is very humble, but is the group in Toronto. I see kids who demonstrated this in a final way. And when they did the study I was referring before, the 25 kids that they did PK before and after switch, the PK went everywhere from 6 hours to 20. And the shortest 6 profile were all in blood group O. And among the highest profile, the longest half-life, there was no blood group O. So it does really matter. And knowing the blood group means you know which kind of PK profile. You can anticipate which kind of PK profile is expected. You still need to do it, but you know that there will be an impact.
I forgot whose turn it is to ask the question. It's probably me then. What what kind of anticipatory guidance do you give adolescent females who become pregnant? Just factor across the placenta. So I don't know if you've had this experience, but Vanessa, can you speak to that?
So I'm assuming they mean a carrier of hemophilia. I'm assuming. So I'm not sure about the factor crossing the placenta. Doctor, do you know for sure if that happens? Like blood flow does, but I wouldn't say that the factor is going to make the patient a non-severe patient as if the person is the carrier.
Again, I'm not sure myself, but I would say no. And the reason is that we are able to diagnose hemophilia in a baby by taking the blood cord. In the blood cord, factor 8, if the patient is an hemophilia patient, will be very low. And in the mother, maybe 50%. So I would assume it doesn't pass the placenta in any significant way. We are not supposed to say brand name here. There's one specific class of factors that are conjugated to a specific FC receptor, and it looks like that one can facilitate crossing the placenta, but in general, factor 8 should not cross.
Thank you. Somebody here is asking, what are some of the challenges preventing PK testing? Or another way to ask might be, are there challenges preventing PK testing?
I think in general, it's typical is the patients not being close to centers. So being able to have someone come in to do blood work is a challenge. We don't typically do labs at external facilities, knowing that they don't process the sample in usually a good time frame. So that can have lead to errors on levels that we receive. Another could be potentially the planning of it. So the resources attached to what it needs to call a patient to ensure that they're infusing, to ensure that it's appropriate and then coming in at a timed appointment. So a lot of it revolves around, is there resources available? Is the patient willing to? What's the distance in which they need to travel? And then the lab capability is another. So potentially some clinics don't have a lab on site. So what does that look like for them with coordination?
I have no barrier to add. I'd like to make a comment though. I think that the barriers are moving from doing a PK study and having a profile to how to use it in clinic. By being involved with the WOPS project, we now see an average of 20, 30 new PK per day, and they come from all over the world. I mean, not anymore a lot from Canada, where almost, I wouldn't say every patient, but the majority of patients has been profiled, but we get, say, 50% of PKs from China, US, and so on. So there are a lot of PKs done, which to me means we are managing to overcome the barrier to do the study. There's much less use of PK to model treatment regimen, pass them on to the app, and then have the MyWOPS in the or my PK Fit in the app of in the hand of the patient, like Michael was suggesting. And I don't know what the barriers are there, but for sure some inertia and, you know, changing the way you practice as a doctor and taking the time to learn as a patient. I would imagine that there are still barriers in adopting a different way of looking at treatment.
I just want to share that in discussing my CBDR with some of our older gentlemen members, they've expressed a fear of the team actually finding out how they're doing their treatments. I'm wondering, Michael, if you can speak to that. Did you have any concern about sharing how you were managing your prophylaxis at home prior to my CBDR?
No, well, we always had to keep a log, but before my CBDR, it was like all handwritten on paper. which was annoying. I did enjoy doing it. The apps are, well, I'm a bit of a computer nerd myself, as you might see by the things surrounding me here. I like the MyCBDR app. It's simple. It's with me all the time. My cell phone is with me all the time. So if I'm out and about, you know, it's there. I always, if I sit down to have my factor 8, my phone is there. And so I really enjoy the new technology. I don't miss the old technology or the old way of doing things at all. Yeah, that's, I think I've answered your question, have I not?
Yes, just
Perfect.
before, oh yeah, go ahead, Rebecca.
No, you go ahead. I was just going to say it's now 8 o'clock Eastern time, so this is the scheduled end time for the webinar. So just wanted to move forward to our closing remarks, but I'll pass back to you, Boyan and Christine, if you want to say a couple words.
All right, just wanted to say thank you to all the panelists for a great set of presentations, and Michael for sharing your experiences. Also to the attendees for all of their really great questions. I think a lot of them were very illuminating for everybody. And it was a great chance to hear, I think, a lot of questions that I didn't even think people had, but that the answers to which were pretty fascinating. So I really enjoyed it. Christine.
Yes, thank you very much, Meducom, for providing the technology for us to be able to have the webinar today, and to CADA for providing the funding. And again, to the panelists, Michael, thank you for sharing. Vanessa, Dr. Iorio, thank you so much for all the effort you put into creating the presentation.